Hi everyone, I am Dr. Ahmed D. Abdulwahab and this is Highlights in Radiology. In today's episode, we will talk about a very important subject, and that is the CT of intracranial hemorrhage. It's one of the most common emergencies, and I think every radiologist need to have the basis of what are they, how they are distributed, how do they look on a CT scan, because our radiology report in this condition will be very significant to the management of the patient. So stay with me. First of all, let's start by defining the types of intracranial hemorrhage. We can divide it basically into two categories. It's either extraaxial or intraaxial. And extraaxial type is divided into four subtypes. That is extradural or epidural, subdural, subarachnoid, and intraventricular hemorrhage. While intraaxial is basically any bleeding that happens within the brain parenchyma. So, what are the causes of intracranial hemorrhage? By far, the most common cause is trauma, okay? Like of all types. However, other causes include vascular malformations, tumor-related, hypertensive hemorrhages are quite common. Rarely, it's either cerebral amyloid angiopathy or cerebral venous thrombosis. So we will not talk into the details of what every hemorrhage looks based on the cause of the hemorrhage. We will just focus on the main categories and how do they look on CT scan. Regarding extradural hemorrhage, also called epidural hemorrhage or epidural hematoma, it's a collection of blood that forms between the inner table of the skull bone and the outer layer of the dura. And as we know, the dura is firmly attached to the bone. So the blood will have to strip the dura from the bone, resulting in a biconvex collection, just like here. You can see it's a biconvex because the dura is stripped from the bone. And since the only thing that passes between the dura and the bone is the artery, usually it's the middle meningeal artery. However, other meningeal branches also pass at the epidural space or the space between the dura and the skull bone. So the bleeding is almost always arterial in nature. It's arterial blood. And since the artery is very strong, the wall of the artery is strong, it's muscle, it needs a significant trauma. That's why usually we have an associated skull fracture. Okay, so whenever you see an epidural hematoma, you have to go to bone window to look for an associated fracture, just like here, because the fracture will cut the artery and resulting in the bleeding. And this why it will be a biconvex collection, and it will have a mass effect. It will cause herniation because it's arterial bleeding, that's active bleeding. And since the dura is adherent to the sutures of the skull, it will be limited by the cranial sutures, okay, but not by venous sinuses, and it can cross and elevate the venous sinus as long as there is no suture related to the sinus. So what does that mean? If you look carefully for this epidural hematoma, here is the coronal suture and here is the lambdoid suture. So the collection or the hematoma will be limited by the sutures. It will not pass them, okay? And at the other side, on the other hand, if there is a venous sinus, it can pass under the sinus, elevate the sinus, as long as there is no suture related to the sinus. So that means it cannot pass or elevate the superior sagittal sinus because there is the sagittal suture related to it, okay? But it can pass under the transverse sinus because there is no suture related to it. Now, let's see some examples of extradural hematoma. For example, here, of course, the density of extradural hematoma will depend on the time at which the imaging is done, okay? If it's acute, chronic, and so on. So, for example, here you can see This is an epidural hematoma. It's biconvex shade. It's limited by the sutures. It has a high density blood indicating an acute hematoma. Okay. We do a bone window or 3D reconstruction, and we can obviously see the fracture line here. What about this one? This is an epidural hematoma here, and it's limited by the coronal suture here, and here it's not reaching the lambdoid, but anyway, it's limited by the suture. However, if you look at the density, it's relatively hypodense compared to the previous one. And why is that? Because this is a more chronic hematoma. When time passes, blood will clot, will be replaced by serum or plasma, and that's why you will have decreased density of the epidural hematoma. Is there any epidural hematoma in this case? Yes, there is. It's an atypical location, that's here at the middle cranial fossa, and as you can see, it is a biconvex collection with a density that's between the acute and the chronic one, so it's probably subacute. Let's look at this one. What about this one? Here we can see a large epidural hematoma, okay, and you can see its density is high. The interesting feature here is we can see these tiny black dots, and these are, of course, air bubbles. So where would air come into the intracranial cavity? Simply because there is an associated fracture somewhere, and it's open to the skin and it's leaking air into the collection. So this confirms the presence of air bubbles, will confirm an open skull fracture. Now, the second type is subdural hematoma or subdural hemorrhage. Subdural space is the space between the dura and the arachnoid, okay? So this space, since the arachnoid is a very loose type of dura, the space is relatively open. It has no significant resistance. And what are type of vessel present in the subdural space? They are mostly veins. And the veins are very thin-walled and very friable and very easy to rupture. So in cases of old people who have diffuse brain atrophy, the subdural space will be big and the veins will be stretched. So any minor trauma might rupture a vein and resulting in subdural hematoma. Sometimes you can't even have a definite history of trauma. Okay, so the blood will spread over the cerebral hemisphere. It will be a crescent in shape, and it might affect any age group, but more commonly we see it in older age population. And since there is no resistance, because not like epidural hematoma, in epidural hematoma, the dura is attached to the bone. Here, there is no attachment, so there is no resistance. The hematoma will be extensive, will be large, okay? And it will not be limited by sutures, because there is no adherence dura to the sutures, but it will be limited by the dural reflections, falx cerebri, falx cerebelli, and tentorium cerebelli. These are dural reflections, will prevent the hematoma from spreading to the other side. And again, the appearance will vary according to the age. For example, you can see here, there is a collection that is taking the shape of the underlying brain, and it's not biconvex, it's crescentic in shape, okay? And it's not limited by any suture, not the lambdoid, not the coronal, no suture is limiting it, but it's limited by the falx cerebri. So you can see it's not crossing the falx cerebri. Now, if you look at this collection here, you can see it's again not limited by a suture, it's crescentic in shape, it's extensive. What's different from the previous one, it has variable density. You can see dense here, hypodense here, because the blood, it's an older hematoma, so the blood is starting to separate into clot and serum, and you sometimes even laceration in the arachnoid matter will result in CSF passing into the hematoma. It will be heterogeneous density. So let's look at it based on the age of the hematoma. If it's hyperacute, which is quite rare to see, because hyperacute means very short time from the onset of hematoma till the CT scan, it will be isodense. It will be similar density to the brain parenchyma, okay? And you can see like here, where is the hematoma? It's not obvious, but if you look carefully, you can see there is a large hematoma here and a large hematoma here, It's crescentic in shape, taking the shape of the brain, so you need to be careful in that. And not always you see a fracture. It's less common to see a fracture with subdural hematoma than with epidural hematoma. And sometimes you might find it heterogeneous due to mix of blood and serum and clotting. But in hyperacute, it usually is isodense. While in acute stage, it's usually homogeneously hyperdense because the blood is starting to clot. You can see here this subdural hematoma is limited by the pulse, and it's homogeneously hyperdense with density more than 50 to 60 Housefield unit. And about 40% of subdural hematomas have a mixed hyper or hypodense area that has unclotted blood, okay? It's serum and CSF going through arachnoid laceration into the collection, like you see here. It's a big subdural hematoma going over the cerebral convexity, causing mass effect and shift to the other side. It's not crossing the dural reflections, but it have different densities, dense and hypodense, due to mixed blood, clot, CSF, serum. Everything is mixed, so it have a heterogeneous density. If patients have a deficient coagulation, okay, they can demonstrate hematocrit level if they are on anticoagulant, for example, or if they have some hemophilia, for example. The blood will sediment and the serum will go up and will have a fluid blood level, okay? And if the patient is anemic, have a low hemoglobin to start, the hematoma may be isodense or hypodense in acute stage. For example, you can see here, this is a blood patient with deficient coagulation, and you can see there is bilateral large subdural hematoma here and there, okay? And you can see there is a hematocrit level. These are the RBCs that are not clotted, and this is the serum. So this indicates either deficient coagulation or some sort of coagulation abnormality. If the patient is anemic to start with, an acute hematoma will be really isodense. You can see here, you cannot even see the hematoma, you just see the mass effect. It's pushing the ventricle to the other side and it's causing mass effect, and you need a very hard window to see the hematoma. The other type of extraaxial hemorrhage is subarachnoid hemorrhage. Subarachnoid hemorrhage has a typical history of the worst headache I have ever had. When you ask the patient, what is wrong? What's your complaint? He says, I have a very severe headache. It's the worst in my entire life. When the patient says that, you immediately suspect subarachnoid hemorrhage. Subarachnoid hemorrhage can be due to trauma or can be spontaneous or idiopathic. And the appearance will be strongly influenced by the amount of blood and the time since the hemorrhage started. What we look for and what we see is a hyperdense material that is filling the subarachnoid space. It's dense material in the subarachnoid space, and usually we see it around the circle of Willis. And why is that? Because circle of Willis is the most common place of aneurysms. You see a lot of aneurysms in the circle of Willis, and they are a common cause of subarachnoid hemorrhage. Like you can see here, you can see this blood in the subarachnoid space, in this cistern surrounding the circle of Willis. It's the pentagon sign, or it looks like a star with 5 arms. So, and the subarachnoid hemorrhage, we will see some examples here. As we said, the appearance will depend on the amount of blood and the duration. So sometimes you just see some increased density at the intraparenchymal cistern, like here. It's a small amount, and it's an indication of subarachnoid hemorrhage. Let's see other examples. For example, here we have subarachnoid hemorrhage here, and it's going over the cerebral convexities. You can see here and here. It's going into the sulci of the brain, and this confirms subarachnoid hemorrhage. It's in the basal cistern here and there, and it's going into the cerebral sulci, and you should look carefully for any signs of subarachnoid hemorrhage. For example, in this case, do we have subarachnoid hemorrhage? Yes, we do. If you look carefully, it's right there over the cerebral convexity, and you need how to differentiate it from a subdural hematoma? Could be subdural hematoma. Well, subdural hematoma, as we said, usually is extensive, it's large. And if you look carefully, you can see the hematoma going into the skull side of the brain, confirming it's a subarachnoid hemorrhage. Another example, you can see here the subarachnoid space is filled with blood all over. The cisterns are all filled and it's like a star, pentagon sign. And what is this here, this big hyperdense something? Well, of course, it's a large aneurysm of the left middle cerebral artery. And this hematoma, this aneurysm is the one that's ruptured and forming a large clot or hematoma. So the fourth type of extraaxial hemorrhage is intraventricular hemorrhage. It's basically blood within the ventricular system of the brain. It has a very high morbidity and mortality. And why is that? Because blood will clot and this will obstruct the CSF, resulting in obstructive hydrocephalus. It can be either primary or secondary. Primary, it's blood within the ventricle only, with little of any blood outside the ventricles, in the parenchyma of the brain. While secondary, there is a large extraventricular component. We will see a lot of examples of that in the coming slides. So will show as a hyperdense material within the ventricle, and since the blood is heavier than CSF, blood will go down and the CSF will go up. Blood will go down, CSF will go up. So we will see it mainly in the occipital horns of the lateral ventricle, because the patient in CT scan is lying supine, so blood will go into the occipital horns. Sometimes if it's severe, it can fill the entire ventricular system, forming a cast, like a mold of the ventricular system. And usually there is an obstructive hydrocephalus with it. You can see here it's a primary intraventricular hemorrhage. There is blood within the ventricle with no blood in the surrounding brain parenchyma. And let's see some other examples. For example, here you can see this is a secondary intraventricular hemorrhage, which is quite common. It's more common than the primary. There is blood within the thalamus here, within the brain parenchyma, and blood within the lateral ventricle. So this is also intraventricular hemorrhage. Again, you can see here there is a large blood within the collection or hematoma within the basal ganglia, and blood filling the ventricular system, and it's heavier than CSF. That's why you see this level, and it's causing obstructive hydrocephalus. Let's see another example. You can see here again blood in the occipital horns forming CSF blood level, and there is a large intraparenchymal hematoma with leaking into the ventricular system. Let's see here again, there is blood in the ventricle here and the ventricle here, forming blood fluid level, and it's filling the occipital horn. Now, let's go to the other category of intracranial hemorrhage, the intraaxial component, which is intraparenchymal hemorrhage. In intraparenchymal hemorrhage, it's an acute accumulation of blood within the brain parenchyma. It's inside the brain parenchyma. It can be either spontaneous, idiopathic, primary, or due to some other pathology, which is secondary, like a tumor, for example. In the CT, we will see hyperdense collection of blood with surrounding hypodense edema. So hyperdense, then surrounding edema, hypodense. And a lot of complications can be present. For example, extension of the hemorrhage into the intracranial compartment, so forms the intraventricular hemorrhage, hydrocephalus, obstructive hydrocephalus, of course, and brain herniation to the opposite side of the bleeding. And the hemorrhage can be anywhere. Can be in the basal ganglia, can be in the thalamus, can be in the cerebellum, in the brainstem, in the cerebral hemispheres, anywhere in the brain, intraparenchymal hemorrhage can happen. Here we have few signs that we need to know in order to describe the hemorrhage in a good way. First of all, we have the swirl sign, which is the presence of a hypodense or isodense regions within the hyperdense intracranial hemorrhage, which represents active bleeding. For example, if you can see here, this is a large hematoma with an areas of hypodensity within the hematoma. And of course, it's causing herniation to the other side. It's going a little bit into the ventricle, causing intraventricular hemorrhage. And this is what's called swirling sign. It's like a swirl. And this indicates active bleeding. Bleeding is still going on. When the swirl sign is encapsulated, when this swirl sign is like well defined and surrounding edema is very obvious, it's called the black hole sign. Okay, black hole sign is the swirl sign, but it's encapsulated. We have what's called the blend sign. Blend sign, it's a presence of relatively hypodense area adjacent to the hyperdense area. Like here, you can see within the hematoma itself, there is a hyperdense area and a hypodense area. So this is called the blend sign. It's presence of hypodense area adjacent to the hyperdense area. And of course, in every CT scan, we have to look for any intraventricular hemorrhage extension. Basically, the hematomas in the thalamus and caudate nucleus or pons are more likely to extend into the ventricle than the hematoma within the cerebral hemispheres, okay, within the lobes of the cerebrum. So let's see some examples of intraparenchymal hematomas. For example, here you can see it's an intraparenchymal hematoma within the cerebellum, and it's well defined and there is no mixed hyperdense, hypodense material indicating it's not active bleeding, okay? Another example you can see here, it's a big hematoma, and obviously there is a swirl sign here surrounding edema, compressing the ventricle, going herniation to the opposite side, indicating a large intraparenchymal hematoma, and this is within the basal ganglia. Let's see another example. You can see here, again, it's in the basal ganglia, extending to the ventricle, to the occipital horn, and it's going into the brain parenchyma, a large intraparenchymal hemorrhage or hematoma, and all of them, this is showing a swirl sign, very obvious because of the hypo and hyperdense mixture. So now we'll have a small quiz. I will show you 5 cases of different types of intracranial hemorrhage. You write in the comment what are your answers. I will give you the answers in few days. Okay, so keep watching. This is the first one. What kind of hematoma is that? Or what kind of intracranial hemorrhage is that? Second one, what kind of intracranial hemorrhage is that? Third, fourth, and the last example or the last question is this. What kind of intracranial hemorrhage is that? So that will be all for this episode. First of all, I want to remind you of this number close adjacent to me. This is the number of the people who are watching us but not subscribed. So we have 65% of our viewers are not subscribed to the channel, which is a very big percentage. So please support us and help us to continue by subscribing to the channel and telling your friends and sharing and liking the episodes. It's a very big help for me, and I will hope that I continue the episodes in the coming weeks. See you next Friday. This was Dr. Ahmed D, Abdulwahab, and this is Highlights in Radiology. Bye.